right. Good afternoon, everyone. Hello, and thank you for joining us here for CIVHC's monthly Change Agent Chat. As most of you know already, I'm Taman Osborne-Roberts, CIVHC's Chief Medical Officer, and your host for today. Now, before we get started, there's just as always a few housekeeping items to mention. One, the phone lines are muted, and we'll be using the Q&A feature to field questions and allow you to make comments on the discussion. Number two, questions posed will be answered during the Q&A session towards the end of the chat. And three, this webinar is being recorded and will be posted to the CIVHC site, so you can access this information again at any time without any cost. Now, before I move to introducing our guest for today, I'd like to discuss just a bit about the reason we're all here, namely data, analytics, and information. Data has become the center of our modern existence. The world's largest and most powerful companies, such as Google and Facebook, are organized around collecting and sharing data. Most of us carry small magical data portals called smartphones in our pockets, using them to access others' data, to share our own data with the rest of the world, sometimes every minute of every day. And frankly, if you're like me, you may even wear a small one on your wrist, which I don't have on right now because it's sitting in my office, but it's normally with me. However, for a range of reasons that we really don't have time to explore today, data use in healthcare, up until recently, has been positively ancient, right out of the Bronze Age. And this is really a loss, for as we all know, the most important part of data is not the numbers, but the people and the good that leveraging information can do for those people. To quote the speaker, author, and social relationship researcher Brene Brown, maybe stories are just data with a soul. And it's you, our partners, that bring that soul into the data supplied by CIVHC, working to change the personal stories of our patients and helping move Colorado and its people forward. In that vein, today we will be speaking with Richard Thompson, Executive Director of the Quality Health Network, or QHN. QHN is Colorado's health information exchange on the Western Slope, and they're preparing to launch the Community Resource Network, or CRN, a care coordination and closed-the-loop referral initiative coupled with a social information exchange. Dick, please take it away.
Thanks, Taman. I'd also like to introduce to our audience Cindy Wilbur, who's the Director of the Community Resource Network, and we'll give you a brief, I'm going to call it level setting, about where we are today and why we're so excited about what we're doing, so to speak, tomorrow, because we're building on those things that do in fact work. So what I'd like to be able to do is see if I can advance that screen, and for some reason it doesn't really want to do that anymore. So I don't know how to move that. It moved before. There we go. All right, here we go. So QHN basically was founded a little over a dozen years ago. A group of stakeholders in Mesa County came together that you see on the screen, and they put together a bolus of capital to begin to do things a little bit differently as it related to improvements in healthcare. And that set of improvements really revolved around the triple aim, but it wasn't called the triple aim in 2004. This is the vision that we had in 2004, which was all about improvement in health status, improve efficiency, and improve patient and provider satisfaction, which later became known as the triple aim. We didn't get the name for it, but everybody's been thinking along those lines for a long time. So the fundamental problem that we were trying to solve a dozen years ago was the silo problem, which is the data is often sequestered in silos. Patients move between those silos for different interventions and different care, and oftentimes the data doesn't. So we've been in the silo busting business at QHN since we went live with our initial quality improvement initiative, which was a health information exchange in October, the 13th to be precise, of 2005. And today in Western Colorado, approximately 94% of all the medical providers in the region use QHN, and about 85% of the healthcare organizations are connected. So everything from hospitals to long-term care to ambulatory care, et cetera. We serve 363 organizations as of the end of December in a variety of different ways. from a vital statistics perspective, we have a little over 3,000 active users. We have more than 85% of the hospitals and healthcare organizations connected. About 1,000 licensed providers, physicians, nurse practitioners, physician assistants are connected. There's about 750,000 unique patients in the Health Information Exchange that have data, and we support millions of queries a year. So having said all of that, if Lori Stevenson were here, who's a quality improvement coordinator at Rocky Mountain Health Plans, she'd probably ask us this two-word question, which is, so what? What difference have we made? Well, there's enough data that would show that we've helped improve efficiencies, that we've helped save some costs, that we've helped improve outcomes. But have we done anything about the healthcare spend? And I think the data about that is pretty obvious. If you look at the curve, if you will, of the cost of healthcare in our country over the last 2 or 3 decades, it's pretty clear it's growing at a rate that's not sustainable. So what, if anything, should we be doing about looking at root causes? And that's what we're so excited about. Once, because we've connected the healthcare providers together, we've connected behavioral health facilities into that healthcare kind of arena. But what have we done about the social impacts, the social determinants of health? And what you see on the screen is it's basically a synopsis, but fundamentally 70 to 80% of the determinants of our health outcomes can be attributed to socioeconomic factors and not the medical care. Medical care, as you see on the screen, is about 10%. Now, the sad fact about this particular pie chart is we've known about this. I've got research papers back in the late 70s. So we've really not done much to address this problem of trying to improve our physical environment, our social and economic factors, and our health behaviors. So what QHN is up to is to begin to link the folks who may have one or more social factors that impact their ability to be healthy, and link them into the healthcare system and the behavioral health systems so that we begin to look at whole person care. One of the exercises that we went through was to ask our stakeholders, all of them, whether they're on the social determinant side or the healthcare side or the behavioral health side, what would you like to know that you don't today? And you can see on the screen a whole host of items that people dreamt about that said, geez, if we only knew when one of my clients appeared somewhere else, if we only knew what interventions were being planned or needed to be planned about that individual. And Cindy, when you were working at the residency, you talked about an instance where many patients had more than one care manager. Can you?
Sure. And so I worked at a safety net practice where we served those that didn't have any ability to pay. And one of the major issues that we found, I had a patient who had 6 case managers in the community, but I didn't know that as I was taking care of her. So we had case management in our practice, and they were sending her to resources and trying to engage resources in the community for her. And she also had 6 other case managers trying to do the same thing. It was super inefficient, and it became a real full-time job for this patient to be compliant with all these recommendations so that she can travel from here and there and just trying to get the resources for her. So the thinking is, if we could deduplicate some of that work, if we could then connect those folks together, it'd be way more efficient, and folks could practice what their specialty is and work on what their office is to do, rather than everybody doing everything for the one person that we're serving.
Yeah. And so one of the things that we learned as a result of there was what was called a Beacon grant that began in 2010, 2011, in which QHN was a participant, which really focused on transforming primary care and begin to use data to help primary care physicians risk stratify their patient panels, understand who needed more prevention or perhaps more attention. And in that process, we began to look at the tail end of it. We began to look at care coordination. And what we found out is, just as Cindy described, it wasn't that care coordination wasn't being done. It was being done by lots of different people, at lots of different times. And so we began a project in conjunction with Rocky Mountain Health Plans that we called Coordinate the Coordinators. And the reason that
sounds like you had care uncoordination.
We had care uncoordination, exactly. So, you know, the discharge planner at the hospital said, oh, I'm in charge. The primary care practice said, no, I'm in charge. Home health might have said, no, I'm in charge. Long-term care may have said, no, we just had the patient, so we're in charge. The health plan's case manager said, no, we're paying for this, we're in charge. And so when everybody's in charge, no one's in charge. So one of the things that we began to do as a result of that was to identify the priorities that we needed to have, and we've carried that forward into what we now have called the Community Resource Network. So pretty basic stuff. Can we identify, first of all, an individual accurately? No matter where they go, it's the same individual. And then can we identify who the care team members are that are intervening on behalf of that individual or ought to be? Can we share that nugget of pertinent and meaningful information among that team of people who are taking care of the individual? And then can we find out what other agencies might be available that would help us take better care of a patient? For example, individual may go into the hospital in an ambulatory way. By that, they're walking. When they leave the hospital, they're in a wheelchair, but they got 5 steps between them and their house if we're going to get them home. Somebody needs to build a ramp, and they probably need to have the ramp built before the patient gets home. So who's going to be in charge of that? We got to figure that out. So that information sharing is pretty basic. Who's the individual? Who are members of the care team? And who's going to do what to whom? And then how do we close that loop? So that care coordination aspect is really what the Community Resource Network is all about. A subset of that is we're helping to fund some of this work through something called the Accountable Health Communities Model Grant, which is it's a grant sponsored by CMS to help us do data collection around the social determinants so that we can identify risk factors that may have to do with transportation or food or housing, et cetera, and then try to do a correlation between that and someone's physical health status and see if an individual who has a couple of social determinant factors working against them, that plus a couple of visits into the healthcare system, perhaps we ought to pay more attention to them. So that's the basics of it. The other thing that came out of it is members of the care team, whether it's the housing authority or whether it's primary care or whether it's subspecialty care, need to understand when that individual presents for care someplace else. So we need to be able to provide notifications to do that work. And if we can do that, then we know where a patient has been or where they might be going, and then we have a much better idea as what needs to be done next. And if we do all of those things, then we should minimize the amount of duplication that we have in our system. And Cindy has coined this phrase because she comes out of the healthcare sector in primary care, is the Community Resource Network cannot be one more thing to do. So can you expound a little bit on that, Cindy? Because the concept is that's the last thing primary care needs.
Well, coming from a primary care background, of course, a lot of different folks would come to you and ask you to do this screening for their agenda, this gathering of information, just put this into your EMR, all those things that continue to happen. And at some point, this 15-minute visit turns into a 45-minute visit because you have all this data entry that you're doing. And so coming from that background, I'm very thoughtful that we don't want just one more thing to happen. This has to be something that's relevant, that makes sense to their workflow, and that they can operationalize this tool however they want to. And just kind of thinking to my background, thinking about the case managers that were in my office, they would spend 30 to 45 minutes on hold just trying to figure out who over at DHS was their case manager so that we can share some information pertinent to their care. Well, if this case manager can get onto a technology that would allow them to figure out who that case manager was, to send them a message asynchronously, and then they can figure out when they want to have their phone call, that's brilliant. And so they're all on board. They want to get on because they just saved 45 minutes of time that they can be providing resources to another patient. So
yeah, no,
does that make sense?
Yeah, I was just saying, speaking on behalf of many of the other primary care providers in the world, thank you. And, I think, well, and to put it numerically, I don't think a lot of people realize that a 1 minute addition to every single visit you have during a day, people go, oh, it's just 1 more minute per visit. Well, that represents a 5 to 7% increase in total time or decrease in productivity, depending on how you want to look at it. And with a high volume, narrow margin business, that's a really, really big problem for primary care practices.
Right. So in the beginning, we're not going to be able to exchange information with everybody's EMR, but I think we're providing a resource that's helpful enough that it's worth doing that extra login to get in there, because it saves them time ultimately, which is my goal, is just to be efficient with everybody's time that serves the patient.
And so some of the work that Cindy's been leading has been, over the past couple of years, we've had groups of folk who come together to kind of work towards a common vision. And that work is really essential to doing this, because if QHN were to do it and say, well, this is the way it's going to be, and it gets delivered as a fait accompli rather than designed by from the grassroots up as to what it is folks actually want and need, it'd be a waste of time. So the whole idea behind this structure is basically to have a whole lot less structure and to listen pretty carefully to the needs of the folks, including patients, who are part of this effort. So because of that, we're focusing on low-cost, secure, streamlined communication. We are focusing on trying to figure out this patchwork quilt of regulation that become detriments to patient care in some cases, obstacles to sharing of information in others, and yet we have to have this balancing act between the rights of individuals to maintain their privacy and the need for folks who are intervening on their behalf to get what they need. So we're discovering all sorts of new terms that go well beyond HIPAA, but that's all part of the work. So if we can have better streamlined communication, reduce duplication of data and efforts, if we can better understand what services an individual is eligible for, it makes a huge difference. And Cindy, I think you were told, you were given some metric about how much time people spend on that eligibility and consent piece.
Well, certainly we have one social service agency that about 0.5 of their FTEs is all about managing releases of information and managing that consent among departments. And so the tool can provide consent management in that they've already agreed to share their information, and then they've agreed to share their information with all of the partners using the tool as a patient. So we don't have to go from department to department to department and sign all these intra-agency releases of information. And so the hope is that they gain some of their FTE time back.
Right. So if we can, particularly in these human service agencies who are strapped for time and resources to begin with, if we can expand the quality and access and scope of their services without increasing their overhead, without increasing their workforce, come on, we think that's a victory.
I agree.
So if one were to look at this in an overly simplistic way, what we're really doing in this endeavor is we're leveraging the people and processes that we have around legal data use, consent to share, all of those kinds of legal documents that are required to move information. And we've been at this since 2005 when we went live, so it's a dozen years or more. Then the other thing that we have to leverage is the ability to clearly understand who we're talking about. And Richard Thompson is one of the worst names for that, because Richard Thompson, is that a Thompson with a P or without a P? Is it a Thompson with an H or not an H? Is it Richard, Richie, Rick, Ricky, Dick? And all of those terms can be used to describe Richard Thompson. So we have to understand very clearly who the person is so we can connect the right data to them over time. And then the third basic building block is we have the ability with the QHN systems in place today to connect and communicate with people at a very large scale at a very low cost. So if you think about this from, we're leveraging what's in place, and we're now adding a social information exchange into the health information exchange and creating the ability with appropriate access and role-based accesses to have different folks be able to see different segments of the individual we're talking about and create a more longitudinal view of them, then we can begin to risk stratify on social determinants, behavioral determinants, and medical determinants. So the argument would be, as we move into new payment models, which is all about outcomes, there are certainly, it's very, very real that one practice's patients are maybe sicker than another practice's. But now we want to enter into and say, you know what, mine are not only sicker, but I have more homeless, I have more transportation challenged, I have more nutrition challenged, and therefore we need to do something different for that group.
So you can get to a level of granularity, not simply about health care, but about health for the patient that we haven't necessarily seen before.
Correct. Correct.
And then ultimately, even moving to a bigger space where you can look at data on a community level and understand where your gaps in care are. Understand you're trying to refer folks for this service and it doesn't exist in your community. And so then have the community leaders come together and figure out how to solve those problems collectively with some data.
Right. And an example of that is we had a recent conversation at the community level about the opioid crisis. And what we found out is that at least in this part of the world, we don't have enough detox capability. And so oftentimes we're putting people behind bars. They don't have detox capabilities. We try to get them out into detox centers, and because of the pressure, they don't really get fully detoxed. Then we put them back out, and they're going to fail. So we don't need to build more jails per se for that population. We need to do a better job of detox before we can put them to work to do something else. So it helps focus about health. So you want to describe basically what the timeline is?
Sure. We really want to work at identifying those basic pieces as a place to start. We have a 5-year timeline, but really the first year is all about who's on the care team, how can I share information back and forth with them, how can I ask them to do a task and know that that patient or client showed up there and did that task and that was a successful referral. Understanding about how to share information with care plans, knowing that we're not going to be one major care plan. That's not the goal here. The goal is to share information that's pertinent to others. So it's a place for care plans to be in a repository for other people to read. Linking households is a really important thing when you're in the social service agencies. Households are just more than family members or guardians, or even just who's paying, in a medical world, it's certainly just who's your guarantor. EMRs don't have a great way of linking households, so we're hoping to get that tool to work for everybody. So I think that's our first year plan, and I think if we can do that, we'd make a lot of folks really happy.
Yeah, we'll get a lot better, a lot faster.
Yeah.
So it's really a whole person approach, which is what we've described. Mm-hmm. And we wanted to see what the questions might be, because this is like an iceberg. We've just barely scratched what's going on here. But Taman?
Well, thank you very, very much for that. And, it might be an iceberg, but it seems like you're chipping away at a fair amount of at least what's visible above the water and, working and getting even lower. We have a couple of questions, coming in. I'd like to encourage everyone to continue to send in additional questions as we continue to chat, because we have about 6 minutes left and plenty of time to ask some things. So our first question is, can you manage mental health services or get consent for mental health services with this consent management tool?
So mental health services are a little bit different in that they'll probably have to do they will have to do some kind of consent management on their side. And so they have a different structure that they'll have to follow. So they'll be able to identify themselves as part of the care team, and each mental health facility gets to interpret their understanding of how they want to operationalize this. But they will share information with us, and so we will have the ability to see that they're part of the care team. But they will do a different consent for themselves and then manage their own consent.
Okay, got it. And our next question, are you using the HL7 standards care coordination paradigm?
The simple answer is pieces of it.
And what's the
we have to be, well, yeah, the hard part here is when we begin looking at human service agencies, HL7's not in their vernacular. we have to be able to meet these agencies in terms of data sharing where they are. And oftentimes where they are is a legal pad and a spreadsheet. And so we have to be able to do what we need to do to move information and share information with them based on what their capabilities are today. And that might be sharing a spreadsheet via comma-separated file structure. It might be on the medical side with HL7 and some of that piece. It might be FHIR. It might be several other technologies. The hard part is that one size does not fit all. And what we've learned as a health information exchange over the last dozen years is just that. You have to be able to meet any organization where they are today and try to get incremental improvements done so that you don't let perfect become the enemy of good and you don't let enemy become the enemy of better. We're just trying to get better. I'm not even sure we're good yet, so much less perfect.
Well, it's always nice to see honesty, but I think you're doing quite a bit out there. In that vein, and really thinking about that, I myself, I think I have a bit of a three-part question. So you really have, come a long way in moving past some of even the common buzzwords we see out there. Folks will talk about community-based participatory research. Folks will discuss, social determinants of health, but you're really moving towards a whole health community, concept, really here. And in doing that, I suppose, I have three questions. One is, you talked a bit about this, but really, what are your explicit next steps? Two, what's the most surprising thing you've found as you've begun to uncover and unpack, really all of this? And then three, if you had a, magic wand or a genie or several trillion on earmarked funds, what would you really do next? What would be your dream list?
Cindy, why don't you start with next steps?
So currently we're in the design phase with the stakeholders. So developing the tool in a way that they want to use it, that's pertinent and meaningful to them and in our community on the Western Slope. So next steps are refining that prototype, starting the pilot, hopefully by the end of March. Take it back to those design members and have them start to pilot in their agencies. That's next steps there.
Surprises?
There's a few.
There's a few. One we can relate is the word patient. The lexicon.
I think lexicon is an interesting thing that we have to deal with, right? We have three different domains communicating, and when they say care plan, for example, well, care plan means something totally different to a social service agency than to a physician, than to a behaviorist. And so even talking about referrals means something different. And I'm a nurse, and in my native nurse language, I call the people I serve a patient. But if I were a social worker in my native social worker language, I would call them a client. And so just having some level setting with the lexicon is super important, I think. And you can get a lot of pushback if you don't have those conversations, and people get offended by terms. And so every meeting I have, we have a conversation at the very beginning about where I'm coming from, what my background is, and why I might say patient, because otherwise I'm translating in my head for my audience and I'm going to make a mistake.
And that's not even to bring in the word consumer. Yeah.
Oh my.
Oh, no, wait. Consumer, member, I mean, client, inmate. I mean, there's just.
So we have to agree to not let our hair get caught on fire because because of the lexicon differences. And this is not about technology, which is, you asked about the third piece. So this is about people and process. So if we could begin a process, this is my wish list, Cindy will have one too. If we could begin the process of, I'm going to call it agency transformation, broadly in the human services side of the equation, so that we could begin to use data to help us drive what happens, when it happens, how it happens. And many of the human service agencies simply don't have the systems in place to do that. Mm-hmm. So think of a lean process that we could use in the human service agency side of the equation to help them use data to become more efficient, more effective, communicate better, understand consent, eligibility, et cetera, that would be a big win. It has nothing to do with technology as much as it does, let's map what the processes are, let's look at the areas that might not be as strong as anybody wants them to be, and see what steps we can make to make improvements there. Cindy, what would you think?
So my magic wish list would probably include having some of those barriers for sharing information reduced. I think that what I'm learning at every social service agency is they have different funder responsibilities, different statutes, different certifications, all those pieces that are stopping them from sharing information. Like maybe I can tell you that they showed up to my office, but I can't tell you if they're eligible for benefits in my office. So I think if we could reduce some of those barriers in a way that the technology could support that privacy of that patient to do so, that'd be my wish.
Got it. Well, thank you for all those answers. And with that, we're actually at the end of our time. This has been an absolutely fantastic discussion, and you're doing some amazing things. Thank you so much, both of you, for joining us and sharing your insights today. Also, thank you to everyone else who has joined us here today. And just to remind you, the recording of the discussion will be shared via social media and the Civic website on Monday. Just to remind everyone, we've now moved to the second Tuesday of each month, still at 12 p.m., so you can continue to eat lunch while you listen. And our next chat is coming up on March 13th. And we will see everyone then. Thank you very much, and have fun out there.
Thanks. Travel safely, Taman.